Thank you very much indeed, and a very warm welcome to everyone to our latest members meeting. As Sonia said, I'm Steve Barnett. I'm the chairman of North West Anglia NHS Foundation Trust, and continuing our theme of clinical topics of interest, the one we're covering this particular meeting is heart failure awareness, and I'm absolutely delighted that we have Kathy Simmonds with us, heart failure nurse specialist, who's going to make a presentation, and then we'll have a few moments at the end should anybody on the call have any questions, and hopefully Kathy will be able to take those on board. So Kathy, if I may, over to you, please.
Thank you for having me very much. I'm delighted to be able to talk to you all about heart failure. It is my passion and has been for the last 15 years. So as I go through the presentation, please use the chat if you've got any questions, but actually I'm quite happy to answer questions through the presentation. If things pop into your mind, just pop your hand up. I'll try and catch them, and we can so I don't mind being interrupted with what I'm saying. So we're going to be talking about heart failure and heart failure awareness, which is such an important topic. I'm going to go through what heart failure is for those of you who are not so sure, and what the burden of heart failure is to communities and to the NHS going forward. We'll be touching on a little bit of the medical management, but more so it's why the medical management is so important rather than the detail of what drugs we're given. And I also want to explain what's happening nationally that we're involved in here in Peterborough and Cambridgeshire and NWAFT, which is part of the 25 in 25 initiative. So I'll explain those numbers as we go through the presentation. Next slide, please. So I wanted to just give you an idea of how important our heart is. It's an amazing organ. And it's made up of, for those of you that are not medical, it's made up of 4 chambers and actually 4 valves as well. We have the 2 top chambers, which are smaller, they're called the atria, and 2 bottom chambers, which are the ventricles. The heart beats approximately 100,000 times each day. It started from before you were born. It's just incredible. And each time it's contracting, it's pumping blood out of the left ventricle to supply the body's organs and muscles with the blood and nutrients and oxygen that they need. So every minute it's pumping out on average about 5 litres or 8 pints of blood. That's what we call the cardiac output. And you multiply that up, it's thousands of litres every day. So the blood is supplying all your cells, tissues and organs with the nutrients they need. However, the heart muscle itself also needs a blood supply, and this is via the coronary arteries. The heart itself also has its built-in pacemaker, and it can work independently of your brain. It is an incredible organ. Next slide, please. So what is heart failure? I think it's clear to, it's important to make clear that heart failure is not a heart attack, although it can be a consequence of a heart attack. And heart failure is not a cardiac arrest, although again, that can be part of a consequence of having heart failure. So what it actually is when the heart fails to pump enough blood on each contraction to meet the demands of the body. So all those numbers that I was telling you about on the previous slide, you know, it's not doing its job properly, basically. And it's caused by abnormalities in the structure or the function of the heart. It causes certain symptoms, and we call it a syndrome rather than a disease itself. And those symptoms are caused by it failing to pump as it should. It doesn't mean your heart will suddenly stop working, although we can never say that, I think, in any situation. However, a diagnosis of heart failure can be very frightening, especially if it's not explained clearly and carefully to people. Next slide, please. So as I've alluded to, I'm sorry the slides seem to have shifted a bit. The heart failure has symptoms which our patients complain of, and then there are signs of heart failure that we are looking for when we're doing our clinical assessment. So the symptoms as listed there, breathlessness is absolutely a common symptom but it is not specific to heart failure. You can be breathless for many reasons, so it's not the only thing that we're looking for. People also complain of not being able to lie flat in bed. This is called orthopnea. And they also can complain of waking up suddenly in the night because they're so breathless. And that's called paroxysmal nocturnal dyspnea. It can result with reduced exercise tolerance, fatigue, and some people experience ankle swelling or unexplained weight gain. But those symptoms are very vague. We as clinicians will look for some of the common signs, including what the heart is sounding like, and looking at for any signs of fluid retention in the body, including ankle swelling, but also in the lungs. Next slide, please. So the British Society of Heart Failure have for a few years been campaigning for better recognition of the common symptoms of heart failure. And these are fatigue, fluid retention, and fighting for breath. So it's been called the F word. And they've produced merchandise or posters like the ones here on the slide to help members of the public to be able to recognize that it and not put down to just getting older, unfit, not being able to do as much, to recognize those symptoms earlier. Because we know now more than ever before that heart failure is treatable. Next slide, please. So what is the problem? What is the burden of heart failure to us as an NHS and to the population? Currently, there's nearly 1 million people living with heart failure in the UK, and there are, in general, more than 200,000 new diagnoses every year. And this figure is predicted to increase by almost another 1 million by 2040. That's a huge increase and a huge rise in incidence. Next slide, please. The other thing that is concerning is that for inpatients in cardiology, we are predicted to have 100% increase in inpatients by 2043, and this is by the Health Education England. That too is something, it's like this tsunami of cardiology and heart failure that's going to be hitting us unless we do something about it now. And that's what I'll be coming on to later. Next slide, please. So why is this increase predicted? People often talk about the baby boomers, those people that were born in the early 60s. Actually, it peaked in 1965. So that generation of population are actually going to be, in 20 years, approaching their 80s. And we know that as the older you get, you're more at risk of developing comorbidities or conditions that can result in limiting factors. We also know that deprivation has a direct impact on premature mortality, as this graph shows. So those that are living in a less deprived area are less likely to die early, essentially. But we also know in our county of Cambridgeshire, 9 out of the 10 most deprived district wards are actually in Peterborough. The other one of those 10 is in Finland. So we are working with a population that is living in quite a deprived areas. Obviously, these are pockets of deprivation, and there are pockets of significant wealth. But still, it is concerning for us in this area. Next slide, please. So again, what other factors are contributing to this potential significant increase in heart failure? So more recently, there has been a steady increase in the number of the population that are now obese. And this chart shows that from the age of 45 to 74, so I can't slide my cursor over this because you won't see it, but those three columns are showing that 3/4 of the population in those age groups are overweight or obese. And we are now leading Europe, sadly, for rates of obesity. But we also know that those who are obese are more likely to develop type 2 diabetes. And we also know that those combinations are also more likely to develop heart failure. So besides coronary artery disease being a cause, we are now looking at significant cause of obesity and type 2 diabetes combined. Next slide, please. I wanted to highlight to you, I'm not sure why the colours are different, but I wanted to highlight to you the where heart failure sits in terms of 5-year survival compared to some of the common cancers, because we hear an awful lot about cancer and the survival rate for 1 year, 5 years, but we don't hear much about heart failure, and yet heart failure has got a worse survival than some of the common cancers. In men, it's worse than having bladder cancer or prostate cancer, and in women, it's worse than breast cancer or colorectal cancer. And there are so much, again, in the media, on the television, about these cancers, and cancer is important to fight. However, there's not an awful lot that is shared about the need to fight the rising incidence of heart failure and the mortality that that brings. Next slide, please. I wanted to just show you the how heart failure can advance over time. And when the heart function is changing, the heart itself begins to reshape. It can dilate, the muscle can thin and weaken as time progresses. And whilst the heart is changing and not functioning as well and becoming less efficient, so too we get this progression of reduced mobility, unable to exercise like people previously could. And these dips in the trajectory of the disease are when there's a significant, like acute symptoms that occur. And sometimes those are associated with hospital admissions. Each time that happens, we don't quite get people back to the level they were at. And each one of those dips on that disease trajectory could actually end in death. And eventually, that's the progression of the disease until one of those dips does end in a patient's death. And next slide, please. So what can we do about this? There are different types of heart failure, and one of the types that has the most evidence base for us to treat is when the heart has we call it a reduced ejection fraction. Obviously, some of you are quite familiar with this, but for those who aren't, that's to do with the amount of blood that's being pumped out of the left ventricle, and it's measured in terms of a percentage. And a normal percentage would be around about 60% of that blood in that ventricle being pumped out. When it's reduced, it's going to be much less than that. And for these patients, it's those that have an ejection fraction that is less than 35 to 40%. For the point of the trials and the evidence, it's less than 35%. So this is the management, medical management, as decided by the European Society of Cardiology. And the top green box shows the first class evidence for treating heart failure with a reduced ejection fraction. And there are 4 groups of drugs plus the water tablets, the diuretics, to get rid of any excess fluid. Next slide, please. This is a simpler, clearer way of demonstrating that. We call it the 4 pillars or the 4 groups of treatment for heart failure. ARNIs are really taking over from ACE inhibitors and ARBs. The evidence is clearly there that they are a better drug for this group of heart failure patients. And then the beta blockers have been around a long time. MRAs are very important and have also been around a long time. And more recently, the new kid on the block is the SGLT2 inhibitors such as dapagliflozin or empagliflozin, which has previously been used in diabetes, but now we know it's beneficial for the heart and it's also renally protective. So these are the 4 different types of drugs that we would want our patients to be on if they have an ejection fraction of less than 35%. And that's on top of their water tablets if they are needing those. It's an awful lot of polypharmacy for one condition, but necessary and improves the patient's risk of admission, their symptoms, improves their quality of life, and it helps to improve mortality as well. And next slide, please. I wanted to just point out why medications are so important. This slide is from the National Heart Failure Audit. Now, it is 2-3 years old, maybe more than that now, actually. And it's only recently that the audit has been measuring how many people are discharged on the ARNI tablet, which is quite new, and the SGLT2. So this is when we were measuring with ACE inhibitors or ARBs, beta blockers and MRAs. And on the, I've forgotten, is it the x-axis or the y-axis? That's bad of me. Anyway, on the bottom axis, where it's not, that's the point of discharge from hospital, and it's the number of days post-discharge. So if you look roughly about between 300 and 400, that's 350 days is about a year. And you can see quite clearly that those patients that have not been given any of the therapy of those 3 groups of medications that I've mentioned, that their prognosis, well, 50% of them will have died within a year. And they're patients that perhaps have just been left on, put on the diuretics to get rid of the fluid, and that's it. So as soon as you start adding in the other medications, the prognosis in a year improves significantly. And this is a clear picture of why medical management for heart failure is so important, and so important to get them on the right treatment if they've been admitted to hospital. Next slide, please. But we also know that patients who are often elderly and they have multiple comorbidities, other problems that are also being treated and managed often with tablets. So polypharmacy is a huge issue. And I'm not going to go into detail in this. This is just to show you the percentage of other conditions alongside somebody who's got heart failure, and how many other conditions they may have. Hypertension is very high in that list, and ischemic heart disease about 50%. But this is quite old data now, actually. This slide is the last data is 2014. It's 10 years ago. So there has been a change since this slide was produced, and obesity and diabetes together are now more of a risk factor for heart failure than ischemic heart disease. So there has been change since then, but the number of comorbidities somebody has is also a predictor of a poor prognosis in heart failure. Next slide, please. So these are our aims really for better outcomes with heart failure. Early and accurate diagnosis means recognizing the symptoms earlier to start the appropriate drug treatment. Getting the diagnosis is with an echo scan. If patients are discharged, we want them as stable as possible to prevent readmission rates increasing, and also to aim for better prognosis, as we've seen with that graph that I showed earlier. And also, it's important to help to promote a better quality of life for our patients. When someone's in an acute phase of heart failure, their quality of life can be quite poor. Breathlessness is absolutely vital for all of us. Well, rather, breathing is vital for all of us. Breathlessness is very limiting. And therefore, we want to try and improve patients' day-to-day living as much as possible. Next slide, please. Next slide, please.
Apologies, my button doesn't seem to be working. I'm trying. Let's see if I can do something else. Bear with me. There we are.
There we are. Okay. So I wanted to talk a little bit about the 25 in 25 initiative. So these are some of the facts and figures that are facing us. 80% of heart failure is currently diagnosed in hospital. Well, this was in 2019. That is dreadful, considering that 40% of those patients probably had symptoms that should have initiated an earlier assessment in primary care in the months prior to admission. We also know that those who have such severe symptoms that they are admitted to hospital, their prognosis is worse than those who have not actually had such a dip in their disease trajectory. And we also know that approximately 400,000 people in the UK are living with heart failure that currently is undetected, undiagnosed, and therefore they're missing out on these medications that can help to preserve their life. And just as there's such a battle about recognizing symptoms for cancer, there should be a battle about recognizing heart failure symptoms early. And there's also evidence to show that deferring heart failure treatment for just 1 month, even in our low risk, perhaps younger patients, increases the risk of death by 1%. That's quite startling. I felt that, and how important it is that we don't delay diagnosis on suspected heart failure when patients are admitted, because there's such a tendency to give them diuretics, improve their symptoms and discharge them, and then they'll get an echo when they're an outpatient, and then it might be another 2 or 3 weeks before that echo. It might then be another 2 or 3 weeks before they're seen by somebody who can start them on their medication. So we're losing time straight away. But really, the big thing is our patients shouldn't be being admitted to hospital for a diagnosis. We need to catch them sooner. And these facts and figures are what the British Society for Heart Failure felt that we need to address nationally. And so they had a big conference in May last year, when lots of clinicians, organisations, charities to do with heart failure got together to work out what we can do about this and about the projected wave of heart failure that could be hitting us in 20 years' time. Next slide, please. So there was a consensus and agreement about changing this trajectory of heart failure to aim to reduce mortality from heart failure in the first year of diagnosis by 25% in 25 years. That doesn't sound like an awful lot, but when you drill down to the numbers, it's saving 5 deaths in every 100, that translates to saving over 10,000 lives per year. And if that was a cancer statistic, there'd be uproar if this wasn't being achieved, and we need to make a noise about it for heart failure as well. Next slide, please. So one of their initiatives, or their main initiative, is to identify some fast-track heart failure communities, and we put in an expression of interest last autumn about being one of their pilot sites, and we were interviewed and accepted as a pilot site. Now this is NWAFT plus Cambridge and Peterborough and Cambridgeshire ICS. So together we can get on board with this initiative and try to change this trajectory. It's the pathway, if you like, is looking right from the beginning, right from prevention. How do you prevent people developing the conditions that can then lead to heart failure? Looking at those that are at risk, which is those patients that have already developed those comorbidities, so the obese patients, the hypertensive patients, those that have had a heart attack, but then identifying the symptoms of heart failure promptly and appropriately, and getting that diagnosis so that then patients can start treatment and improve their quality of life. It sounds so simple, and yet it seems such a challenge. So we are one of 7 pilot sites that are working with the BSH and their project managers to look at what we can do here. And whilst we're very much on board in NWAFT, in the trust, we also need GP practices to get on board with this, because actually that's where patients first present. And we need to get on board with raising awareness with the general public about these symptoms and who they should, when they should go to their GP, and that getting those pathways right so that we can get the diagnosis and the treatment. Next slide, please. So this on the left is the roadmap that the BSH came up with, and it's basically what I've been talking about in terms of prevention first. Is so important. So lifestyle advice, exercise, healthy diets, awareness, really, education and awareness, and just a realization that the path that some people are on, often in those deprived areas where lifestyle is not prioritized, where healthy eating and healthy lifestyle is not prioritized, are those that are going to develop conditions that could lead to heart failure. So we're thinking of diabetes, obesity, conditions that might lead to a heart attack, which then subsequently leads to heart failure, perhaps hypertension, atrial fibrillation, and also the poor circulation, the impact on kidney disease, and so this pathway, like I said, it's a little bit of a confusing roadmap when you look at it straight away, but really we're talking about prevention strategies, identifying those at risk, early accurate diagnosis and appropriate treatment, but making every contact count. However, it has to start with public engagement with and awareness of the signs and symptoms to look out for. But we want to be able to detect those that are not detected yet, because they're going to land up in our hospitals, and we want to make sure they're on the right treatment. Next slide, please. So what can you do? Help us. It's being aware of those at risk of developing heart failure for our clinicians among us, for our members of the public to be aware of the symptoms and the link with comorbidities. We need to get a really good pathway for early and accurate diagnosis, and echo is absolutely, I think here in the trust we're well aware that there is there's been a backlog of echo scans, but it's and that's being worked on, I know. And then obviously the appropriate and timely evidence-based treatment. We're the trust here have invested in our heart failure nurse team. We're very, very grateful because we were getting run ragged. We have now increased our clinics for titration of medications, so we've got more outpatient work going on. We're now involved with the virtual ward and supporting what's going on with the virtual ward and our patients post-discharge. And we're seeing patients in ambulatory care settings rather than having them admitted, and we're supervising IV diuretics here at Hinchinbrook, and because that's where I'm talking from at the minute, but also at Peterborough as well. And so there are plans and developments going which we're able to get involved with and push forward from the heart failure nurse service point of view, because we've had that investment in our team, which we are hugely grateful for. And that's my last slide. Are there any questions?
Thank you very much indeed, Kathy, for a really excellent presentation on such an important topic. I can see that one or two folk will be putting their hands up, but to start with, we have a question in the chat box.
Sorry, I missed that.
With access to primary care and the demand on GPs, how is North Place promoting this pilot?
Right. We have some meetings. We've had some meetings with one or two members of the ICB. Now, I am a secondary care nurse through and through. I've never worked in the community, so I don't understand all the changes to organisations that has gone on in the community. But I've also, we've reached out to GP practices. So I have done this presentation quite recently, actually, only a couple of weeks ago, to about 50 GPs. And I've been asked to repeat that again with some in October. And I've spoken to practice nurses, pharmacists, and paramedics as well. Really, obviously looking a bit more at the detail of medical management of heart failure, but promoting this, the 25 in 25 project. We did Heart Failure Awareness Week in the Trust, and that raised awareness for some staff that were able to come to our talk, but also we spoke to many members of the public at Stamford, Peterborough, and Hinchinbrook hospitals during that week. And we are planning other events to raise awareness with the public, because that's where it starts, really.
Thank you, Kathy. And we have a question now from Dr. Callum Gardner, who is the Chief Medical Officer for the Trust. Callum.
Yes.
Thank you, Chair. It was more just saying well done on the presentation, Kathy, and thank you for all that you and the team are doing. I just wanted to highlight for colleagues that I don't think we should underestimate the amount of work that went into this pilot and the bid when we did the interview, and the president of the British Society of Heart Failure personally fed back to me it was one of the best presentations they saw nationally, and there was a lot of interest. So really just well done for me. This is a really, really important piece of work. So thank you.
Thank you. Thank you.
Callum, and we have a question in the chat box from Mary. What's the expected timeline from referral to echo for diagnosis purposes?
So I'm not personally involved with the triaging of echoes. Our consultants are working very, very hard. I mean, the triaging of referrals for echo and cardiology review. We're well aware that at the moment there is a longer time frame that there should be. The NICE guidance clearly says that GPs should refer in for specialist review for 2 weeks if there be NT-proBNP, which I haven't mentioned actually in my talk, is high. So that's over 2,000. And if it's raised between 400 and 2,000, there is a slightly longer time frame. It's 6 weeks. We are not meeting that. I don't think many areas are. in the east of England. But that is our target. As I said, we're not meeting that at the moment, but there is work going on so that we should be able to achieve that. But I know that our cardiologists are spending quite a bit of time working on triaging the referrals that come in so that we're prioritizing those that really are more urgent. And we know that NT-proBNPs can be affected by other things, like renal impairment. Age is another thing. Even if somebody's currently on medication or obesity, and there's other factors. AF is another factor. So those things have to be taken into account to try and prioritize those that really are, developing heart failure symptoms.
Thank you. Further question here from Anne. Go ahead, Anne. You're on mute, Anne.
Can we unmute Anne?
Unfortunately,
We can't
not.
unmute her, no.
Oh.
I have been speaking to her though, so I know that she can. She has been able to talk. We were talking
You're
before
still
the
on
meeting
mute,
started.
Now
Okay.
can you?
There you
We
are.
can hear you now, yes.
Yeah.
Yeah,
Please
the,
go-
the
please go
icon
ahead.
moves around the screen. How viable do you think it would be, maybe, to raise funding to treat these symptoms and stuff like we've treated breast cancer? That you make mobile clinics that drive round and advertised well in the area, in the community centres, that people can voluntarily go to those buses and have the tests, the blood tests and everything else, and the blood pressure tests, and then be referred on.
I think that's a very good question. We are actually looking at utilizing a bus that is, I don't know who owns it, to be honest. I don't know who drives it, but I'm sort of in the early stages of looking at whether we can have a like public awareness event utilizing a bus. I don't know whether we'd be able to do blood tests on that bus, but we could certainly be checking blood pressures, checking for weight and height. We haven't looked at the detail yet, but it's on the cards, because I think some sort of a public event outside of the hospital would be good and would help to raise awareness. We do need to make sure, though, that our GPs are aware that we're doing this, because what might happen is a sudden influx of requests for GP appointments, and to get into the process. And so there's a lot of communication, I think, so that everybody in our area is on board with it. So we're just beginning to think that. It's a very good idea, Anne. Thank you.
Thank you.
Thank you, Kathy. Thank you, Anne. Do we have any more questions? If you do, could you just press your hand raised button, please? I can't see any further questions.
There is one gentleman who's physically put his hand up, Keith.
Oh.
Yes, he's waving. There you go. Unmute yourself.
Yeah. Hi. Hi. Just to let you know, I chair an organisation called SHIAC, and we run education events using the Art Centre in Stamford.
Okay.
So we could produce an event for a whole afternoon or an evening, as you require, on this issue.
Okay. Well, that may be something to pursue. I'm up for more ideas. So I've got your name here, or maybe I could be given your email. And do you run this? Would you be the contact to
Yes,
get in touch
I
with?
would. Yes.
Okay. Okay.
No
Kevin,
problem.
was it you that sent an email earlier in the week?
Yes, it is.
I have forwarded his
yes. Okay.
contact on to you, Kathy.
Thank you. Yes, Keith, I did get that email. I haven't responded yet to it. I do only work part time now, unfortunately. So I had some time off, and in fact, I'm going on annual leave after tomorrow as well.
So you should.
So yeah.
That's a very kind offer, Keith. Thank you very much.
So
indeed for
yes,
your-
I will be getting in touch with you. Thank you.
Yeah.
I have your email.
We're going to take you
Yeah.
up on that kind offer.
Fine, that's
Yeah.
thanks.
Okay, so I don't see any more hands up. So it just remains for me on behalf of all of us to say a huge thank you to Kathy for a wonderful, thought-provoking presentation today. But more importantly, an even bigger thank you, Kathy, to you and the team for all that you continue to do for our patients. We are hugely grateful to you. Thank you very much
I
indeed.
appreciate that. Thank you.
And thank you everyone for joining us this afternoon, and look forward to our next members meeting where we will have another topical clinical subject matter for us to consider. Thank you very much indeed, everyone. Have a pleasant evening. Thank you.
Thank you.
Thank you.
Thank
Good
you.
night,
Bye
everyone.
bye.
Bye.
Bye-bye.
Bye.
Bye-bye.
Katie, do you want to stop the recording?